Hello, my name is Elsa Guerra. I'm a Keuka College student, and today we'll be talking about fall prevention in hospitals. Let's review some of the objectives and the reason why we teach about fall prevention. The reason why we teach about fall prevention is to promote a staff education on fall risk assessment, to identify the plan of care for fall prevention, to understand steps that we need to take when a fall occurs, and also to promote a safety culture that includes the patient, our staff, and family members. Some quick facts here about falls. The average hospital cost for one fall can round up to $35,000, and that is some data received by CDC in 2012. The leading cause of injury death for Americans 65 years and older is falls, surprisingly. Each year, 1 in 3 adults 65 years and older will have a fall. 30% of the hospitalizations of patients with falls result in injury, with as many as 20% with hip fractures resulting in death within the first year of injury. That is quite a high number. 25% of adults who lived independently previous to a fall have to spend a minimum 1 year in the nursing home or a rehab facility. Now we're looking at falls problem as it affects our patients in the hospital. Who is affected from a fall in the hospital? Any patient 60 years or older, patients with a history of falls in the past, patients who have undergone surgical procedures and are in high-risk drugs such as PCA, opiate sedatives, elderly patients who suffer from urgency, frequency, incontinence of urine or bowel, patients who are tethered to equipment such as IVs, catheters, chest tubes, which makes pretty much the biggest population of our patients in the hospital. Patients who have mobility risks, they have a broken leg, a broken arm, they've had neck surgery and cannot move as freely as they did before, and also patients who cognition is altered. How do we differentiate falls in hospitals? We start by accidental falls, which means patient is tripping over IV pole, falls out of bed as they're trying to reach something, or slips in water or cords. Anticipated physiological falls. This patient has a high risk of falling because of medical conditions such as diabetes, hyper or hypotension, dementia, as well as abnormal gait or high-risk medications, as we mentioned before, or urinary frequency. And then we have unanticipated physiological falls, which we could not possibly prevent because we don't know when they're going to happen. Usually they happen during, if the patient has suffered an event such as seizure or stroke or fainting episode that results in a fall. And then lastly, we have behavioral or intentional falls. Patients are acting out, they're mad at staff, want more pain medication, etc. Let's review injury levels that can happen due to a fall. We start with no injury happens as a result of a fall, and there's no signs or symptoms of an injury as determined on a post-fall evaluation, which may include an X-ray or CT scan ordered by the provider. With minor injuries, we result in application of an ice pack or a dressing or cleaning of the wound or limb elevation, pain medication, there's a bruise, but no more damage than that. A moderate level of injury results in suturing, application of steri strips or skin glue, splinting, or might be a muscle or joint strain. So that's basically the extent of it. With major injury, these are big falls that result in surgery, an intervention that's going to happen to the patient, casting, traction, required sometimes a neurologist consult, especially for patients who are on anticoagulant therapies. And then the highest level, obviously, of injury is death. The patient dies as a result of fall injury. Within an aging population, both number of falls and the cost to treat injuries are likely to increase in hospitals, requiring hospitals to develop effective fall prevention strategies. At St. Joe's, we have patient safety care bundles, which include the safety huddle, the hourly rounding, Morse scale that every patient will get, individualized care intervention, and post-fall follow-up. The safety huddle, it has to happen on each floor of the hospital, and the purpose of it is to consistently identify at all shifts the safety needs for each patient. Hourly rounding, we're talking about a purposeful rounding that seeks to improve the patient experience through the use of a structured hourly rounding. And for it to happen when we visit a patient every hour, we have to accomplish scheduled tasks, address the 5 Ps, address personal needs, questions, conduct a visual assessment of the environment, like bed alarms, IV pumps, where everything is located in the room that, can cause a patient to fall or trip. Asking the patient if there's any other needs that we need to address, and also stating when we're going to be back to reassess them. The Morse scale is a scale or an assessment tool that has to be done in admission, daily shift, if patient's cognition or there's a change in the patient's level of cognition or health, upon transfer and after each fall. It gives a score based on the history of falls, secondary diagnosis, ambulatory aid, IVs that are in the patient, gait and how the patient transfers, and the mental status. And based upon the score that we get from Morse scale, we develop an individualized care intervention, which could be from applying socks, a bracelet that indicates potential for falls, hip protectors, floor mats for the patient, or a posy sitter if they are out of bed into a chair, or bed alarms if they are staying in bed. And then after all this is applied, if there's still a fall that happens, we always have a post-fall follow-up. All protocol, it has to be done and followed for each fall in the hospital. It includes taking the vital signs by nurse and assessing the patient immediately. Falls that change from baseline of the patient's health require notification to the doctor immediately. If there is a definite change in the cognition, we are supposed to call rapid responses. After assessment of the patient, we need to document in an event tab. We have to document the notification, report patients attending, and review patient's current regime of medication such as anticoagulants. And on the day shift or evening shift, notify unit manager, or in the off shifts, there's a call that needs to go to the director of that particular unit, and of course update the Morse scale so we can do an individualized plan for this patient. Also very important is to complete a fall quality assessment tracking form so hospital can track the falls. Why did they happen? What could we have done better to prevent it? Or are we missing something in the process of fall prevention? And also, it's very important to notify the family after we have done all the previous steps. Post-fall diffusing is also another very important step because it will help us to quickly formulate an approach for immediate care between all the team members, review the treatment or what do we need to do right now, review the situation and prevention for future potential situations that could have adverse outcomes for the patient, families, and staff in general. What are our responsibilities as staff members of the hospital? To begin with, is the correct patient receives intended services, meaning based on what we mentioned before on initial assessment, on the Morse score, every patient gets what is needed to help them and protect them from a possible fall in the hospital. All staff participates in the detection and the management of actual and potential risks to patient safety. What can we do to make the environment safer for our patients? All staff models non-punitive attitude that emphasizes system failure rather than individual failure. We look into what we have as methods of protecting our patients and what do we need to improve. That's why reporting it's very important so we can follow these falls that have happened in the past and document near misses or near harm events so we can go back and review and change our plan of care, for example. And also respond in timely manners to crisis situations that have patient safety implication. Administrative responsibilities. What are our senior leadership responsibilities? These include developing a safety culture and a non-blame culture, so everybody can report near misses and not feel guilty about it. Promote a teamwork. Everybody should be involved in our patient safety. Monitor risk reports for trends and safety issues so we can review the preventative action plans. Conduct a culture of safety assessment, survey at regular intervals, utilizing standardized tools, and foster an environment in which patients, families, and staff altogether are involved to identify and manage potential risks. Include the families. They're very important. They know their patient. They know how they act. So it's very important to have their perspective into the matter. And also provide organizational guidance to the falls problem. And now, after reviewing some of the most important points on the fall prevention in hospital, we open the floor to questions. Do you have any questions, any concerns, or any new side of fall prevention that we have not discussed? What do other hospitals do to prevent falls? Do they have different protocols? Do they have different interventions that you'd like to share? And my question is, what could we do better to decrease falls when working with nursing shortage, changes in the workflow, and more complex patients? Thank you.